Welcome to the Rad Onc Smart Review GI Cancer series. This is really a dedicated tutoring session designed to help you cut through all the noise and get straight to the essential knowledge you need.
Yeah, we're glad you're joining us.
We are ready to, dissect another really pivotal topic in oncology today.
And today, we're picking up right where we left off, diving back into pancreatic cancer, specifically focusing on what we're calling Pancreas Part 2, the neoadjuvant revolution for resectable and borderline resectable pancreatic cancer.
It sounds dramatic, revolution, but it really fits, doesn't it?
It really does. I mean, this isn't just some minor adjustment in sequencing. It's genuinely one of the most profound paradigm shifts we've seen in modern GI oncology. It's changed everything.
Absolutely. And we're talking about fundamentally rethinking when we deliver the heavy-hitting therapy, moving it from, mostly after surgery to mostly before surgery.
Right, the preoperative setting.
And for you, as residents kind of navigating this complex field, understanding the critical reasons behind this shift, why it's gained so much traction, and what it means for patient care, well, it's absolutely crucial.
It really is. You might remember from our last discussion, even after a really tough surgery, like a Whipple procedure.
Which is a massive operation.
Huge. Even after that, the long-term outlook for many pancreatic cancer patients often remained, well, guarded, even with upfront surgery.
Yeah, that reality check, the fact that recurrence rates stayed stubbornly high even when surgeons felt they got it all.
Exactly. That challenging reality is precisely what fueled this whole push, this acceleration towards neoadjuvant therapy. We sort of realized maybe waiting until after surgery is just too late to make the biggest impact.
So our mission today is simple. Equip you with a really solid understanding of this revolution. We'll start by defining surgical candidacy, getting really granular on the NCCN criteria based on vascular anatomy. That's foundational.
Absolutely foundational. Can't stress that enough. Then we'll dive into the landmark trials, the ones that are, shaping our current standards, but also sparking some really fascinating ongoing debates in the field.
And it's not just the science, right? We want to translate this into practice. So we'll cover essential clinical decision-making points, stuff you'll actually face in tumor boards.
Definitely. We'll walk through some classic board-style cases to make sure these concepts stick.
And, of course, pull out some high-yield clinical pearls to help you navigate these, let's face it, really complex scenarios confidently.
Okay, let's get started. Where do we begin?
Let's start with the big why. Why this massive push towards neoadjuvant therapy? You touched on it, but let's really unpack it. It stems from that stark realization. Upfront surgery often wasn't the cure we hoped for.
That's exactly it. That's the core issue. Even with our best imaging, advanced CT, MRI giving us incredible detail.
Yeah, the pictures look good sometimes.
Right. But even so, we kept seeing this disturbing pattern in major trials. Big studies like ESPAC4, Protégé-24, looking at upfront surgery.
What did they show?
They consistently show that even for patients we thought had clearly resectable disease on scans, the rate of a positive microscopic margin and R1 resection was just astonishingly high.
Like, how high are we talking?
We're talking like 40 to 60%, sometimes even higher in some series.
Wow, so nearly half, maybe more, had microscopic cancer left behind, even after a Whipple.
Precisely. Even with what looked like a clean resection to the surgeon's eye, under the microscope, nearly half the time. There was still disease at the edge. And that's not just a pathology report detail, it's a direct barrier to cure.
And that R1 resection, that positive margin, it really cranks up the risk, doesn't it?
Hugely. It significantly increases the risk of the cancer coming back locally, right there on the surgical bed, and systemically spreading elsewhere in the body.
Which obviously impacts outcomes, impacts survival in a big way.
Absolutely. This is such a critical point for you to grasp. If almost half of our upfront surgeries are leaving microscopic disease behind, we desperately need a better strategy right from the start. Otherwise, we're always playing catch-up.
So that's where neoadjuvant therapy comes in. You mentioned it has advantages.
Right. It offers 3 really key advantages that directly tackle these challenges we just laid out. These advantages are designed to sort of set the patient up for a better success from the very beginning.
Okay, what's the first one?
The first one, and arguably one of the most compelling, is better patient selection. Neoadjuvant therapy acts like a real-world test, an in vivo test, for the tumor's biology.
What do you mean by in vivo test?
Well, think about it. If a patient's cancer is just inherently super aggressive, destined to spread quickly, or if they already have tiny micrometastases we couldn't see on the initial scans, that aggressive nature will often reveal itself during the neoadjuvant treatment, During the chemotherapy or chemoradiation, the cancer might grow despite treatment, or new spots might appear.
Ah, I see. So it's like a stress test for the cancer.
Exactly. It lets us see the true biological behavior before we commit that patient to a massive high morbidity surgery like a Whipple,
Which means?
which means patients who unfortunately show progression despite getting potent upfront therapy are then spared the significant physical toll, the potential complications, the long recovery,
Hmm.
all from a surgery that wouldn't have helped them long-term anyway because the disease was already systemic or just too aggressive.
That makes a lot of sense. It's identifying the non-responders early.
Precisely. It's a more humane approach and strategically vital. We ensure our most aggressive local treatment, the surgery, is directed towards those who actually have a fighting chance of benefiting from it.
Okay, patient selection. That's powerful. What's the second advantage?
The second major advantage is achieving higher R0 resection rates. Remember, R0 means a completely clean margin, no cancer cells left at the edge.
Right, the gold standard.
The gold standard for potentially curative surgery. By giving systemic therapy, and often radiation, before surgery.
You shrink the tumor?
Exactly. We can often shrink the primary tumor, sometimes quite dramatically. We
Yeah.
call it downstaging. But it's not just about shrinking the main mass. It's also about treating that microscopic disease that might have crept just beyond the visible edges.
Cleaning up the area.
Cleaning up the surgical field, essentially. This gives the surgeon a much better shot at getting all the way around the tumor and achieving that critical, clean, margin-negative R0 resection.
And we know R0 leads to better outcomes.
Directly translates to improved local control, fewer local recurrences, and often significantly better long-term survival.
Makes sense. Okay, advantage 3.
Advantage number 3 is incredibly practical, but really important, especially given how tough modern pancreatic cancer chemo regimens are. It's the improved delivery of systemic therapy.
How so?
Patients are generally stronger, fitter, in better overall shape before they undergo a major debilitating operation like a pancreatoduodenectomy.
Right, they haven't had the stress of surgery and recovery yet.
Exactly. That pre-surgical window allows them to tolerate the really intensive chemotherapy regimens, like FOLFIRINOX, much better.
Which is the standard for many fit patients now.
It is. And administering these potent drugs when the patient's performance status is at its peak maximizes the effectiveness of the systemic treatment. That's critical for hitting both the local disease and any hidden micrometastases floating around.
So you're hitting the cancer hard systemically when the patient is best able to handle it.
Got it. You're leveraging their peak physical resilience to deliver the most impactful therapy possible, instead of trying to give that same tough chemo when they're weak, recovering from surgery, maybe malnourished or immunocompromised.
Okay, that really clarifies the why. It's about selecting better, resecting better, and treating systemically better.
Does it up perfectly.
You used an analogy earlier about fixing a roof.
Ah, yes. Think of upfront surgery, especially with those high R1 rates, like trying to fix a really complex, leaky roof right in the middle of a hurricane. The patient then needs to recover from that major fix before you can even start reinforcing the rest of the house, the systemic therapy.
Okay.
Neoadjuvant therapy, on the other hand, is like shoring up the entire foundation, meticulously sealing all the cracks, reinforcing the whole structure during calm weather when the house is stable and ready for the work.
So you optimize everything before the big operation.
Precisely. You optimize all the conditions for the best possible outcome up front.
Yeah.
It's proactive, strategic, multidisciplinary, right from day one, not just reacting after the fact. That's the fundamental shift.
That makes the rationale really clear. So if we're deciding who gets this neoadjuvant approach, it hinges on those NCCN definitions you mentioned.
Absolutely. The entire initial decision-making process, whether a patient is even a surgical candidate, let alone whether they need neoadjuvant therapy, pivots on how the tumor relates to the major blood vessels back there in the retroperitoneum.
And the NCCN, the National Comprehensive Cancer Network, gives us the rulebook for this.
Exactly. They provide very clear, universally accepted definitions based on high-quality CT or MRI scans. You absolutely must know these definitions cold. They guide initial management, staging, and honestly, every single tumor board discussion you'll ever have about pancreatic cancer.
Okay, let's break them down then. Start with the best case scenario, resectable disease.
Right. Resectable. From a purely anatomical surgical view, this is what you hope to see. On the arterial side, think arteries first. There must be clean, clear, fat planes separating the tumor from the critical arteries.
Which arteries are key here?
The big ones. The celiac axis, the superior mesenteric artery, SMA, and the common hepatic artery. For a tumor to be truly resectable, there should be absolutely no contact between the tumor and these arteries. Zero contact, just clean fat in between.
So plenty of room for the surgeon to work.
Exactly. Now moving to the venous side, the veins for resectable disease, it's a little different. There can be some contact.
Oh, okay. Which veins?
The superior mesenteric vein, SMV, or the portal vein. Some contact is allowed, but it has to be limited. Specifically, less than or equal to 180 degrees of the vein circumference.
So touching less than half the way around.
Right. And critically, even with that limited contact, there must be no distortion of the vein's contour. No narrowing, no bulging, no sign that the tumor is actually invading and changing the vein's shape. It implies just a superficial touch, easy to peel off surgically.
Got it. Clear fat around arteries, limited, non-distorting contact with veins. That's resectable.
Precisely. Now let's get into the more nuanced category. Borderline resectable disease. This is really where the neoadjuvant approach has made its biggest impact. These are the patients who benefit immensely from treatment before surgery.
Okay, borderline. What defines this? Arterial side first.
Arterial side for borderline. If the tumor merely touches or abuts the SMA or the celiac artery.
Just touching.
Just touching, yes. And that abutment is up to 180 degrees of the artery circumference. It's not wrapping around, not encasing it, just making contact along part of the vessel wall.
And that automatically makes it borderline.
Yes. That abutment itself creates a high risk for leaving microscopic disease behind an R1 margin if you go straight to surgery. So arterial abutment up to 180 degrees equals borderline.
Okay. What about the venous side for borderline?
Venous side for borderline. This is where it gets a bit more complex. If there is distortion of the SMV or portal vein or significant narrowing, or even if the tumor contact is greater than 180 degrees.
That sounds pretty involved.
It is.
Yeah.
But it can still be considered borderline if, and this is the absolute key distinction, there's still a sufficient length of healthy, normal vein, both above and below the area of tumor involvement.
Why is that important?
Because that healthy segment allows for a potential surgical reconstruction. The surgeon can remove the involved segment of vein along with the tumor and then sew the healthy ends back together or use a graft. That reconstructability is what keeps it in the borderline category rather than unresectable.
So even with significant vein involvement, if a reconstruction is technically possible, it's borderline.
Exactly. It's definitely a higher risk situation for surgery, requires specialized vascular surgical skills, but it's still potentially achievable after neoadjuvant therapy shrinks the tumor and cools down the inflammation around the vessels.
Okay, that clarifies borderline. Now the final category, unresectable disease.
Unresectable. This means surgery with the aim of cure is essentially off the table because of the extent of vascular involvement. It's defined by features that make getting an R0 resection impossible or extremely unlikely.
What are those features? Arterial side.
Arterial encasement. If the tumor wraps more than 180 degrees around the SMA or the celiac axis, truly encasing the vessel like a cuff. That's unresectable. Trying to peel the tumor off the artery in that situation almost guarantees leaving gross disease behind.
So more than 180 degrees around an artery equals unresectable.
Correct. Or, alternatively, on the venous side, if there's an unreconstructible SMV or portal vein, meaning the tumor involvement is so extensive along the vein that there isn't a healthy segment above and below to connect to. The surgeon simply has nothing viable to sew back together after removing the involved portion.
So either major arterial encasement or venous involvement so bad it can't be fixed.
Exactly. Those are the anatomical roadblocks that define unresectability based on NCCN criteria.
That's a lot to remember, especially the degrees of contact.
It is, but it's crucial. Here's a quick mnemonic, specifically for the arterial side, which often causes confusion. For arteries, remember, abutment is borderline. Encasement is unresectable.
Abutment, 180-degree borderline. Encasement, 180 degrees unresectable.
Nail that down. That distinction, that 180-degree threshold for arteries is absolutely paramount. It comes up constantly on boards and in every single tumor board discussion. You need to internalize that.
Okay, definitions locked in. Now let's talk evidence. Where's the proof that this neoadjuvant approach actually works better?
Great question. With those definitions clear, we can now explore the clinical trials that really underpin this whole shift. The first major trial to provide that crucial level 1 evidence supporting a neoadjuvant strategy for both resectable and borderline resectable patients was the Dutch PREOPANC-1 trial.
PREOPANC-1, okay, this sounds important.
Hugely important. A landmark study you absolutely have to know inside and out. It fundamentally changed practice worldwide.
What did it do?
It was published in the Journal of Clinical Oncology, a top journal. It elegantly randomized patients, both resectable and borderline, into two groups.
Group 1.
Group 1 was the standard approach at the time, upfront surgery, followed by adjuvant chemotherapy with gemcitabine.
And Group 2.
Group 2 got the experimental neoadjuvant approach first, then surgery if possible, and then, if they recovered well enough, potentially more gemcitabine afterwards.
And what was that neoadjuvant regimen in PREOPANC-1? You mentioned it was unique.
It was quite specific, yes.
Yep.
And definitely worth remembering. It started with one cycle of just gemcitabine chemotherapy, sort of like a primer.
Okay.
Then, that was followed by a course of chemoradiation therapy.
Radiation details.
The radiation dose was 36 gray, delivered in 15 fractions. That works out to 2.4 gray per fraction. And importantly, they received gemcitabine concurrently with the radiation.
So chemo and radiation together.
Right, not an integrated approach. And after finishing the chemoradiation, patients got one more cycle of just gemcitabine before finally heading to surgery.
Wow, that's quite a structured lead up to the operation.
Very structured, designed to maximize both systemic and local effects before the surgeon even picked up a scalpel.
So what happened? What were the results?
The key outcomes were honestly game-changing, really dramatic. The neoadjuvant approach profoundly improved the rate of achieving that critical R0 resection, the clean margin.
How much improvement?
The R0 rate jumped from a pretty concerning 40% in the upfront surgery group.
40% R0, meaning 60% were R1 or R2.
Exactly. 60% had positive margins with upfront surgery in that trial. But in the neoadjuvant arm, the R0 rate climbed to an impressive 71%.
71%, so it nearly doubled the chance of a completely clean resection.
It did, demonstrating a powerful local effect of the neoadjuvant chemoradiation strategy. But it gets better.
Survival.
Survival. With long-term follow-up, the neoadjuvant therapy group showed a clear, statistically significant overall survival benefit.
What were the numbers?
The 5-year overall survival rate in the neoadjuvant arm was 21%.
Okay, 21% at 5 years. And the upfront surgery arm?
Only 7%.
7 versus 21%.
A threefold improvement in 5-year survival.
That's huge for pancreatic cancer.
It's massive. PREOPANC-1, without question, provided the first definitive high-level evidence that this specific neoadjuvant chemoradiation strategy doesn't just improve R0 rates, but most importantly, it translates into significantly better long-term survival for these patients. It truly established a new benchmark.
So PREOPANC-1, gemcitabine-based chemoradiation, 36 GI in 15 fractions, improved R0, improved survival.
Got it. Exactly. But while PREOPANC used gemcitabine, we know that today the most potent chemotherapy we have, especially for fitter patients, is FOLFIRINOX.
Right, the multi-agent regimen. Much stronger, but also more toxic.
Correct. And that brings us to another highly influential, but also, frankly, quite controversial trial that you absolutely need to understand. The Alliance A-0-2-1-5-0-1 trial.
Alliance, okay.
Yeah.
What was the focus here?
This trial specifically looked at a FOLFIRINOX-based neoadjuvant strategy, and it focused only on patients with borderline resectable disease.
So not resectable, just borderline.
Correct. It was designed as a randomized phase 2 trial. Importantly, both arms got intensive chemotherapy with FOLFIRINOX. The key question wasn't chemo versus no chemo, but rather
adding radiation help.
Exactly. Did adding local radiation therapy, specifically SBRT in this case, on top of the powerful FOLFIRINOX chemo provide any additional benefit for these borderline patients?
Okay, what were the two arms?
Arm 1 received 8 cycles of modified FOLFIRINOX, slightly adjusted doses for better tolerance, followed directly by surgery. Chemo only.
Arm 2.
Arm 2 got 7 cycles of modified FOLFIRINOX first.
Yeah.
Then they underwent SBRT, stereotactic body radiation therapy.
SBRT dose.
The dose range was 33 to 40 gray, delivered in just 5 fractions. A very concentrated high-dose course.
Yeah.
After the SBRT, they then went on to surgery.
So FOLFIRINOX alone versus FOLFIRINOX plus SBRT, the hypothesis being SBRT would boost local control or R0 rates.
That was the idea.
Yeah.
But this is where the Alliance trial gets really interesting and honestly a bit messy. It requires a really critical look at the trial design and how results can sometimes be misleading if you don't dig deeper.
Uh-oh. What happened?
Well, first off, the trial was stopped early. That's always something that makes you pause and ask why.
Why was it stopped?
It was stopped because the SBRT arm hit a predefined futility boundary, specifically for achieving a low R0 resection rate. It looked like the SBRT wasn't delivering the expected improvement in clean margins.
Okay, that doesn't sound good for SBRT.
On the surface, no. And then came the survival analysis. Now, this was an exploratory analysis, not the primary endpoint, but it got a lot of attention.
What did it show?
It showed that the median overall survival for the chemo-only arm, it's just FOLFIRINOX, was an excellent 29.8 months.
Almost 30 months. That's fantastic for borderline pancreatic cancer.
Truly fantastic. A real testament to how effective a FOLFIRINOX is systemically. But the median overall survival for the chemo plus SBRT arm was only 17.1 months.
Wait, 17 months compared to almost 30.
Exactly. On the surface, this looked like a massive blow against radiation.
Yeah.
It seemed like adding SBRT actually made things worse. It caused a huge stir, a lot of debate, a lot of confusion.
Wow. So what's the catch? You said it's controversial.
The catch is, and this is absolutely critical for you as residents learning to appraise data, a deeper dive reveals some significant flaws in the trial's design and execution that make that conclusion that SBRT was harmful highly unreliable. You can't just take that headline result at face value.
Okay, let's hear the flaws. Flaw number 1.
Flaw number 1 involves patient selection and progression. It turned out, possibly just by bad luck of randomization or maybe some subtle selection issues, that the SBRT arm had a higher proportion of patients whose cancer progressed systemically.
Meaning it spread elsewhere.
Yes.
Okay.
And crucially, this progression often happened during the initial FOLFIRINOX chemotherapy phase before they were even scheduled to get the SBRT.
So they never even got the radiation.
A significant number of patients randomized to the SBRT arm never actually received SBRT because their disease got worse systemically first. But their poor outcomes were still counted within the SBRT arm results.
So the arm looked worse, partly because it included patients who progressed early, unrelated to the radiation they never received.
Precisely. A major confounding factor right there.
Okay, flaw number 2.
Flaw number 2 was the futility endpoint itself. The trial rigidly used the R0 resection rate as a primary measure for stopping early due to futility.
What's wrong with that? Isn't R0 important?
R0 is very important. But think about how this played out. If a patient was randomized to the SBRT arm, started FOLFIRINOX, and then developed, say, liver metastases.
They wouldn't go to surgery.
Correct. They became unresectable. And because they didn't get to surgery to even attempt an R0 resection, their outcome was immediately counted as a failure of the SBRT strategy.
Even though the SBRT hadn't even been delivered yet, and the failure was due to systemic progression on chemo.
Exactly. The trial design essentially penalized the SBRT arm for events, systemic progression during chemo, that happened before the SBRT was even given. This created a highly artificial signal suggesting SBRT was futile in achieving R0 resections.
That seems like a really problematic design choice.
It was widely criticized later. And flaw number 3, especially relevant for us as radiation oncologists,
Yes?
was the radiation target volume.
Yeah.
The SBRT in the Alliance trial was delivered only to the gross tumor volume, the GTV, just the visible tumor on the scans.
What's the issue with that?
The issue is, we know pancreatic cancer often spreads microscopically along nerves, perineural invasion, and around blood vessels, perivascular invasion, well beyond the visible GTV. Standard radiation fields usually include elective coverage of these high-risk pathways.
But Alliance didn't cover those pathways.
No, it was GTV-only SBRT. This limited target volume might have compromised the radiation's ability to sterilize all the local microscopic disease, potentially impacting both local control and the R0 resection rate, compared to a more comprehensive radiation approach.
Okay, so putting it all together, patient selection issues, a flawed futility endpoint, and maybe a suboptimal radiation target.
Exactly. So the big take-home message from Alliance A-0-2-1-5-0-1 is absolutely not that SBRT is bad or harmful in this setting. That's a misinterpretation.
What is the takeaway then?
What the trial powerfully demonstrates is that modified FOLFIRINOX alone is an incredibly effective neoadjuvant systemic strategy for borderline resectable pancreatic cancer. The nearly 30-month survival in the chemo-only arm proved that.
So the trial confirmed the strength of FOLFIRINOX.
Absolutely. The poor outcome seen in the SBRT arm is far more likely a reflection of these deep trial design problems and the patient selection biases we talked about, rather than a true negative effect of radiation itself.
So it highlights how crucial trial design is and how careful we need to be interpreting results.
Precisely. It doesn't tell us radiation doesn't work. It tells us this specific trial couldn't properly evaluate its role because of these issues. It really underscored the need for careful integration and sequencing and maybe different trial designs to answer the radiation question properly.
That's a much more nuanced understanding. Really important to grasp those details.
Crucial, don't let the initial shock headlines from that trial mislead your thinking about radiation's role.
Okay, let's crystallize this. Time for some high-yield clinical pearls. What are the absolute must-know points from today?
All right, pearl number 1. The neoadjuvant approach is now strongly favored for most seemingly resectable pancreatic cancers, and it's absolutely the standard of care for all borderline resectable pancreatic cancers, period.
Why again?
Driven by those historically high R1 rates 40 to 60% with upfront surgery alone, we simply know we can achieve better R0 rates and likely better survival by treating first.
Got it. Neoadjuvant first. Pearl number 2.
Pearl number 2. You absolutely must know your NCCN vascular criteria for defining resectability, borderline, and unresectable disease like the back of your hand. Arterial abutment versus encasement, venous reconstructibility.
Not just for exams.
Not at all. It's your fundamental guide for initial management and every single tumor board discussion. Nail it down.
Okay. Pearl 3.
Pearl number 3. The PREOPANC-1 trial provides our strongest level 1 evidence that neoadjuvant chemoradiation specifically, that 36D Vojai in 15 fractions with gemcitabine regimen significantly improves overall survival for both resectable and borderline patients. That threefold improvement in 5-year survival is key evidence.
PREOPANC equals survival benefit. And Paul 4.
And pearl number 4, relating to the controversial trial. While Alliance A-0-2-1-5-0-1 showed outstanding results for modified FOLFIRINOX alone, its conclusions about SBRT need to be interpreted with extreme caution. Remember the flaws: patient selection, futility endpoint, GTV-only target. Don't jump to the conclusion that SBRT is ineffective based solely on that trial's headline results.
Excellent summary. Those 4 pearls really capture the key takeaways.
Hope so. Ready to apply them.
Let's do it. Time for a board blitz.
All right, I'll give you a classic board-style case. Listen carefully, pause the audio if you need to think, formulate your answer based on our discussion, and then we'll break it down.
Sounds good. Lay it on me.
Case 1. A 62-year-old man is diagnosed with a pancreatic head adenocarcinoma. His staging CT scan shows the tumor is abutting the superior mesenteric artery, the SMA, for approximately 90 degrees. There's no frank encasement. The SMV portal vein confluence looks patent. No issues there. What is the NCCN resectability status? Your options are A, resectable, B, borderline resectable, C, unresectable, D, metastatic.
Okay. 90-degree abutment of the SMA. Patent veins. NCCN status. Pause. All right. I think the answer is B, borderline resectable.
You got it.
Yeah.
B, borderline resectable is absolutely correct.
Because, as per NCCN guidelines, any abutment of the SMA, as long as it's 180 degrees or less, automatically pushes the tumor into the borderline resectable category. Even though the veins are clear, that arterial contact is the key factor here.
Exactly. That 90-degree abutment signifies a high risk for a positive margin with upfront surgery, making neoadjuvant therapy the standard of care for this patient. Perfect.
Okay, ready for case 2.
Case 2. A 63-year-old woman is diagnosed with ductal adenocarcinoma of the pancreatic head. Her imaging identifies 270-degree contact with the portal vein. It also shows 90-degree contact with the common hepatic artery. The celiac and superior mesenteric arteries are noted to be free of tumor involvement. Which of the following is the most appropriate next step in management? Your options are A, radical surgery, B, neoadjuvant chemoradiation with 36 gray in 15 fractions, C, neoadjuvant SBRT with 50 gray in 5 fractions, D, immunotherapy.
Okay. 270-degree portal vein contact, 90-degree common hepatic artery contact, SMA and celiac are clear. Pause. This feels borderline too, so neoadjuvant therapy is needed. Option B uses the PREOPANC-1 regimen. Option C is SBRT. Immunotherapy isn't standard here, so between B and C, given the level 1 evidence from PREOPANC, I'm going with B.
Excellent reasoning. The best answer is indeed B, neoadjuvant chemoradiation, with 36 gray in 15 fractions. Let's break down why. First, the staging. The combination of greater than 180-degree venous involvement, the 270-degree portal vein contact, even if potentially reconstructible, plus arterial abutment, the 90-degree common hepatic artery contact, makes this a classic borderline resectable tumor by NCCN criteria.
Right, both arterial and venous criteria point to borderline.
Exactly. Since it's clearly borderline, neoadjuvant therapy is mandatory. Upfront surgery, option A, is incorrect. Immunotherapy, option D, isn't standard first-line treatment here. So it boils down to the type of neoadjuvant therapy.
A versus C.
Right, and as you correctly pointed out, the PREOPANC-1 trial provides our best level 1 evidence, specifically showing a significant overall survival benefit for using neoadjuvant chemoradiation with that exact regimen 36 gray and 15 fractions, typically with concurrent gemcitabine in both resectable and borderline resectable patients. While SBRT, option C, is used in some centers based on other data and the Alliance trial despite its issues, option B represents the approach with the strongest supporting evidence for a survival benefit in this specific scenario presented in a board question.
Makes sense. Go with the level 1 evidence when it's available.
Generally a good strategy for boards. Okay, one more. Case 3. Adjuvant radiation therapy is being recommended for a patient who underwent a pancreatoduodenectomy, a Whipple procedure, for ductal adenocarcinoma of the pancreatic head. The final pathology report showed a microscopically positive margin, an R1 resection. What is the most likely site of that positive margin? Your options are A, uncinate or retroperitoneal SMA margin, B, portal vein groove, C, pancreatic neck margin, D, peripancreatic soft tissue margin.
The positive margin after a Whipple. Where is it most common? I remember we discussed this. The tricky area near the big artery. Pause. I think it's A, the uncinate SMA margin.
You nailed it again. A, uncinate or retroperitoneal SMA margin is correct. This is a super high yield point. The most common location for an R1 resection after a Whipple procedure is indeed the uncinate process.
And why is that again?
Anatomically, the superior mesenteric artery, the SMA, runs directly behind this uncinate process tissue. This creates a very tight space, leaving very little wiggle room for the surgeon to get a wide margin around the tumor in that specific area.
So it's just anatomically challenging.
Extremely challenging. It's inherently a high-risk spot for microscopic residual disease, which is another powerful reason why neoadjuvant therapy, aimed at shrinking the tumor and sterilizing those margins before surgery, is so important. It helps mitigate this inherent surgical challenge.
Great cases. They really tie the concepts together.
Good. That's the goal. Now let's talk about putting this all together in the real world, in clinic.
Right. We have the definitions, the trials, the pearls. How do we synthesize this when making decisions for actual patients, often in those multidisciplinary tumor boards?
Okay, let's start with clearly resectable pancreatic cancer. Historically, upfront surgery was the default, but now
This shifting.
it's definitely shifting, based largely on the PREOPANC-1 data and the persistent worry about those high R1 rates, even in resectable cases. Many centers and guidelines now strongly support considering neoadjuvant therapy, and often actually favor it.
Even if the scans look perfectly resectable by NCCN.
Even then, because we know the scans can underestimate microscopic spread, and the R1 rates are still concerningly high historically with upfront surgery. So the neoadjuvant approach is increasingly used to maximize the chance of an R0 resection, optimize systemic therapy delivery, and hopefully improve long-term survival, even for patients who could technically go straight to the OR.
So that tumor board discussion for a resectable patient is now more complex. It's not just, can we operate, but should we operate now or treat first?
Exactly, you'll discuss. Is it truly anatomically resectable? What's the patient's fitness level for chemo? What are their comorbidities? And critically, what's the overarching goal? Just getting the tumor out. Or maximizing the chance of long-term cure, which usually requires hitting potential micrometastases hard with systemic therapy early.
Makes sense. Now, what about borderline resectable?
For borderline resectable disease, it's much more straightforward now. There's essentially no debate left. Neoadjuvant therapy is the undisputed standard of care. Full stop.
Why so definitive?
Because the risk of an R1 resection with upfront surgery in borderline cases is simply too high. These are the patients where neoadjuvant therapy-intensive systemic chemo, often combined with radiation, is absolutely essential to try and downstage the tumor, sterilize those close margins, treat microscopic disease, and give the patient the best shot at achieving an R0 resection later.
So borderline equals neoadjuvant therapy required.
Absolutely. Now, regarding the type of treatment.
Right, the techniques. We mentioned conventional chemoradiation and SBRT.
Correct. We have the chemoradiation approach, like in PREOPANC-1, 36 gray and 15 fractions with concurrent gemcitabine. That's a very common, well-established, evidence-based regimen.
And the alternative?
The alternative, often discussed, is SBRT, stereotactic body radiation therapy. As explored in Alliance, this typically involves higher doses per fraction over a much shorter time, like 33 to 40 gray in just 5 fractions.
Both aiming for local control?
Both aiming for potent local control, yes. But how they fit with systemic therapy, their side effect profiles, and the strength of evidence supporting them differs.
And this leads to debate, right? Chemo first, then radiation. Chemo and radiation together. Just chemo.
Exactly. That's the core of many tumor board discussions currently. The Alliance trial, despite its flaws, really highlighted how effective FOLFIRINOX alone is systemically. That strong signal pushed many centers towards giving a longer course of chemotherapy up front, often for several months, to maximize systemic control first.
But what about the local control part? Does radiation still add value after all that chemo?
That's the million-dollar question the field is still actively grappling with. Does adding local therapy, whether it's conventional chemoradiation or SBRT, after potent systemic therapy, further improve R0 rates and ultimately survival? Or is the systemic effect from FOLFIRINOX so dominant that the added benefit of radiation is marginal, or maybe only needed for certain patients?
So ongoing research is looking at timing and integration.
Precisely. When is the best time to give radiation? Before chemo? After chemo? Maybe integrated within the chemo cycles? What's the optimal radiation dose and target volume in the context of modern chemo? Should we be using SBRT or conventional fractionation? These are the questions driving current clinical trials and daily clinical decision-making. You will be part of these discussions constantly.
And patient factors play a big role too, I imagine.
Huge role. Not everyone can tolerate 8 cycles of FOLFIRINOX followed by chemoradiation or SBRT. Managing the toxicities, the neutropenia, the fatigue, the neuropathy, the GI issues is critical.
So a frail patient might get a different approach.
Absolutely. For a less fit patient, you might consider a less intensive chemo regimen, maybe shorter course radiation like SBRT if local control is a major concern and they can tolerate it. Or perhaps even omitting radiation altogether if systemic control is the priority and their tolerance is limited. It's highly individualized.
And assessing response after neoadjuvant therapy can be tricky too.
It can be. Sometimes a tumor doesn't shrink much on scans, but it becomes very fibrotic, indicating a good pathologic response that the scan doesn't fully capture. This requires really close collaboration between radiology, surgery, and oncology to interpret the post-treatment imaging and decide on the best next step, usually surgery, if feasible.
So lots of nuances in applying this in practice.
Definitely. It's a constantly evolving field, driven by new trial data, better understanding of tumor biology, and refined techniques. But the core principle, neoadjuvant therapy first for borderline, and increasingly for resectable, is now firmly established.
Okay, great overview of the clinical decision-making process. Let's try and summarize the key points from our whole discussion today.
Sounds good. So today, we really charted this revolutionary shift, this move towards neoadjuvant therapy for both resectable and borderline resectable pancreatic cancer. It's been a true paradigm change in GI oncology.
We meticulously defined those crucial NCCN vascular criteria that guide the initial assessment and decision-making. And hopefully that mnemonic for arteries abutment is borderline, encasement is unresectable will really stick with you. It's fundamental.
Absolutely. We then dove deep into the 2 landmark trials really shaping current practice. PREOPANC-1, providing level 1 evidence for neoadjuvant chemoradiation, improving survival.
And Alliance A-0-2-1-5-0-1, which powerfully demonstrated the efficacy of FOLFIRINOX, but whose conclusions about SBRT need very careful critical interpretation due to those significant trial design issues we unpacked.
Right. We highlighted that the neoadjuvant approach is now the preferred strategy for most resectable and all borderline resectable pancreatic cancers, primarily driven by the goal of overcoming those historically high R1 resection rates seen with upfront surgery.
And, crucially, while Alliance showed FOLFIRINOX alone yields excellent results, we need to be extremely cautious about overinterpreting its findings regarding SBRT due to those specific trial limitations. The story there is much more complex.
Exactly. It's about understanding the nuances behind the headlines.
So reflecting on all this, especially the mixed signals from trials like Alliance, it leaves us with a really interesting question, doesn't it?
It does. As we keep refining our strategies, what does this complex data landscape really tell us about the optimal way to combine our best tools, powerful systemic chemo, and effective local radiation?
Yeah, is it just a simple question of if we should use radiation, or is it maybe more about when is the best time to deploy it and how, what technique, what dose, what target to truly make it complement and synergize with regimens like FOLFIRINOX, ultimately pushing survival rates even higher for our patients?
That's the critical question driving the next waves of research and clinical trials. How do we best integrate these potent therapies for maximal benefit? It's something you'll see evolve throughout your careers.
A fascinating challenge for the field.
Indeed.
All right, that brings us to the end of this session.
For detailed show notes from today, and importantly, to complete practice oral board scenarios based on this material, make sure you visit radoncsmartlearn.com. That's radonsmartlearn.com.
And definitely subscribe to the Rad Onc Smart review series so you don't miss our next comprehensive tutoring session.
We hope this breakdown was helpful.
Thanks so much for tuning in and joining us for this exploration of the neoadjuvant revolution in pancreatic cancer. We look forward to having you back next time.